Thanks. Am I on?
You are up.
All right, all good. Thanks very much, everybody, for coming. And what we're going to do is we're going to try and get to as many questions as possible. As many questions as possible. And so we're going to try and limit the answers. We will not get to all of them. Some will be perhaps less appropriate for this kind of context if it's very specific to one particular person asking essentially a very restricted question about their particular care. And some we're not maybe necessarily experts in, insurance questions and other things like that. So we'll try and just go one to one and just keep on going through. And if you think of more, you're welcome to ask more questions. We'll try and get to them over time. So we'll start with Dr. Gross. And they're going to pick out the questions. We all have sort of separated them by category, and then we'll go around.
Just one at a time?
One at a time, yeah.
Okay. My first question was, any comments are use and usefulness of CBD for managing MS symptoms and pain, thoughts about dosing and frequency? Yeah, I mean, as I talked about in my talk, I think there's a lot we don't know. I certainly do talk to my patients about it. And, you know, especially because we're in Colorado and it's pretty accessible. And then I, you know, try to solicit from them, like if they go out and do it, well, did it help you? You know, like what did you use? Like what was the ratio? That kind of thing. I mean, you know, I think it's still, there's a lot of unanswered questions about that. I couldn't even begin to tell you anything about dosing or frequency. I don't even know who could, but yeah, hopefully we'll get some more kind of, you know, controlled trials in the next few years that we can kind of start to get into some of those and get answers from them. But yeah, in the meantime, people are definitely using it, and yeah, I just say be careful. Yeah.
All right, Amanda.
Is there any relationship between contracting COVID and then getting diagnosed with MS? The short answer is no. There's no studies with a direct link between COVID and then developing MS. There is a longer, perhaps more convoluted, hand-waving answer of not MS, but more broadly speaking, autoimmunity or autoimmune disease and the COVID virus. I know we're supposed to keep our answers short.
No, you're fine.
But for COVID, it's a very inflammatory virus, and there are small studies, looking at patients and looking at their inflammatory blood markers when they got severe COVID in the hospital setting. And so we don't necessarily see this with mild COVID, but when we have severe COVID and you're hospitalized in the ICU, you can see blood markers of cytokines like IL-6, IL-10, IL-1 beta, and these markers are just markers of inflammation, and they can cause downstream effects on the immune system, activating things like B cells and antibody production. And so there is one theory, and it is a theory that maybe when you have this degree of inflammation, it lowers your kind of tolerance in the immune system, and you can produce antibodies and develop autoimmunity. But the short answer is no.
All right, Enrique.
All right, I got a cluster of questions around BTK inhibitors, maybe not surprising since I give the talk on BTK inhibitors, but around sort of like where do they fit in and what do we, like relationships to other drugs. So the reality is we don't know. They look like they're going to be stronger than kind of the old platform medications. As far as, you know, do they fit into that top category? The data on tolebrutinib suggests that. The data on evobrutinib, as it gets reanalyzed, looks like it's going to be kind of, that at least for relapsing MS, they're going to be in that higher category as well. But the data that we have from primary endpoint kind of stuff from their phase 2 studies suggests that they're going to be much more like in the middle group tier of drugs. As far as kind of any BTKs inhibitors, they're not approved in the US for MS yet, and they're going to be a couple years. There are BTK inhibitors approved for cancer. And as far as kind of where they are in the treatment algorithm, like are they like comparison to the old drugs, you know, I kind of said that. As far as being able to be part of the studies, the tricky part is because they're being compared to kind of the lower tier drugs for us, and knowing how we like to treat with higher efficacy drugs. we're mostly reserving them for patients that are newly diagnosed, because you need to have some disease activity to get into the studies. And then patients that are probably newly diagnosed. So if you're breaking through on another drug, we probably don't want to take the risk of you ending up on a low efficacy drug, such as the comparison drug for those studies. And so we're looking at newly diagnosed patients with milder disease that, where being on those drugs might be okay to do that. And so that's kind of where we're looking at them for now.
Great. And I got several relatively quick questions about supplements and other things like that. One is there any benefit to taking vitamin B12? If your vitamin B12 is deficient, if it is low, you can have nervous system complications related to that in the spinal cord or in the peripheral nerves, or even with cognitive dysfunction. So we frequently check B12 levels, because they also, if you're deficient, can cause little white dots on a brain scan. So we are frequently checking them, at least when we first see someone. And if you're deficient, it is useful. If you want to try and treat MS itself, there's no evidence that it does anything, to my knowledge. As I alluded to previously with regard to heat, I did not discuss heat intolerance. We're coming up on the summer weather here. Exercising, we still want you to exercise even if it's hot, but you do it maybe in the morning. You do it when it's cooler. You bring cool liquids with you. You wear the least amount of clothing possible, or stay inside in a air-conditioned room. And so you change the ambient environment to try and help to avoid heat problems, and then adjust your behavior based on that. But if you need to go somewhere, you want to go somewhere, you want to go to your kid's soccer game, it's 2:00 in the afternoon in July, you can wear a cooling vest or a cooling necklace or a cooling forearm pad that will help with keeping your body temperature cool. Are there any supplements that are available that we know will promote brain health, specifically in MS or even in general? I'd say the things that you see on TV, those are supplements for which there's no data whatsoever, and they're all anecdotal, and they have people who will tell you how wonderfully they do on those, like Prevagen and other ones. There's absolutely no data I'm aware of, because I have checked, in any disease state, and certainly not with multiple sclerosis. The problem with supplements like that is that they can make many claims that are not regulated by the FDA, pretty much. And so it's very difficult to know. They don't do randomized controlled trials. And so most of them are pretty much making it up. Anything with regard to controlling diet, working to limit symptoms, everyone's gut is going to be a little bit different. Some people will have diets that, for example, produce more gas, or other things inside their gut, maybe are constipating. What I generally tell people is that the dietary information that we have is relatively limited, and you should eat a diet that, number one, is overall healthy. So you don't want a high fat or high sugar diet. You should use a diet that you sleep well with, you can exercise well with, that you feel well with, and they have good gut health with. And that is probably the best recommendation right now, and that would be related to controlling at least gut symptoms. I'm not aware that there's any specific diet, though, that changes fatigue, or other than what I showed before, suggesting that Mediterranean diet and that paleo diets probably got the best data supporting them overall. Rob?
Yeah, so I actually got a couple of questions here about temperature as well, although not, I mean, I agree with Dr. Corboy about kind of how you can kind of manage your symptoms if they're exacerbated by extremes of hot or cold. But the questions here seem to be more about having trouble regulating one's own body temperature. Is that normal with MS, and getting cold or hot flashes throughout the day, variations in temperature at time of sleep, things like that. So yeah, I would say that that's definitely less well understood than that other phenomenon of just symptoms worsening, like other neurological symptoms worsening in extreme temperatures. I mean, I can kind of postulate some mechanisms that might be the case. I have heard, occasionally I'll get patients who tell me this kind of thing, so it probably reflects a real phenomenon. There's kind of the main part of the brain that deals with temperature regulation, hypothalamus, is an area that, to my knowledge, doesn't necessarily get hit with MS plaques that frequently. It can get damaged in other disease processes. I could also imagine, like, if you have, because pain and temperature are often, they're transmitted by the same kind of nerve fibers, and so if you have numbness, you're not able to feel, sensation. It could potentially involve, temperature sensation as well, which could potentially lead to things like differences in your behavior, not bundling up if you need to, or what happened or whatnot. You've also got descending fibers, autonomic things in your spinal cord that could potentially get hit by an MS plaque, which could lead to temperature dysregulation, which I really think this is, I'm going to do some more digging after this, but yeah, I don't know that it's as well understood.
If I can, I'll add one comment to that. You may see more low thyroid function in patients with MS, especially women, and sometimes with interferons or other drugs we use. And that can be associated with a feeling of coldness if you have low thyroid
Yeah,
function.
absolutely. Oh, and obviously, like, you can also be going through menopause if you're having hot flashes,
Right.
or things like that. So yeah, you always want to check for other kind of hormonal potential, things in there.
All right, Amanda?
All right, so I'm going to sync up a couple questions here because I got some questions on specific DMTs and COVID vaccination. So what about vaccine response with Tecfidera? So the non-infusion medications. I highlighted a lot of the infusion medications in the talk because the greatest concern on that graph that was a little difficult to read was really with the anti-CD20s with the greatest amount of immune suppression. On that table, Tecfidera actually had a pretty good immune response to vaccination, and there wasn't as much concern with immune suppression there. And then, as a follow-up question, someone asked about switching from a predominant B-cell DMT, such as Ocrevus, to something like Myzant, or more of a T-cell driven or T-cell drug. And so when you're making switches with your DMTs, it's probably worth a conversation with your neurologist or physician APP to talk about the timing of the vaccine. Once the Ocrevus wears off, usually somewhere between 6 and 9 months, you start having those B cells repopulate, and vaccinating when those B cells start repopulating would be an ideal time to get that nice antibody response.
A couple more questions on BTK inhibitors. So as far as, like, for the patients that had liver issues, was there something else that kind of contributed to those liver issues? It depends on how far you want to extend it out. I think, there was one patient that definitely had, some alcohol use and, things like that. But I think as more cases start to come out, it becomes a little bit harder to kind of blame it on other stuff. And it probably looks like it's a little bit related to the drug that was being studied. So I think a little bit more of that to kind of come, but just, a little bit on that. There was a very eloquent question that I'm less eloquently going to answer about remyelination and BTK inhibitors, in talking about sort of how much of the symptoms are related to remyelination and how can we improve with that, and how is that being looked at with the BTK inhibitor in their studies. And the problem a little bit is that we can only measure function, and it's really hard to kind of separate, are we measuring remyelination, or are the nerves connecting better, and those kinds of things. So we're not smart enough yet to kind of separate out and tease out sort of like how much it's helping remyelination versus axon sprouting versus, or dendrite sprouting, or reconnection of dendrites, or those things. So I think some of those things are the things that they're trying to explore with these studies. And there's a lot of things that they are kind of looking at within the trials to see, like, can we tease those things out using like really special MRI sequences. For some of the trials, there are spinal taps that are optional, and we actually have had decent success in getting some patients involved in doing those kinds of studies. And then we can potentially see, are the markers for like microglia activation going up or down? Are the myelin markers, myelin basic protein or PLP going up or down or things like that? So there's a lot of efforts in that, but it's going to be hard to kind of tease out some of those things. But that's being looked at in sort of the measures of progression versus, more inflammation directly type markers as well. So I think we're going to learn a lot, as these studies kind of read out. Now, don't expect that stuff to come out as fast as like some of the primary results for the studies. Those things tend time to analyze and things like that. So in a year or two after the readout of the studies, we'll start to kind of see, some of that other stuff kind of come out as well.
All righty, I have one brief question about alcohol use, and then I'll speak a little bit about discontinuation and what happens with aging with MS. The question for alcohol is any data on alcohol consumption and multiple sclerosis. I'm not aware of any specific data, for example, looking at impact on either MS outcomes or on symptoms, but I think it's pretty clear that alcohol is a central nervous system toxin, also a peripheral nervous system toxin. So if you are an alcoholic, you can clearly cause damage to your brain and or peripheral nerves that would be in addition to whatever problems you have due to aging and due to multiple sclerosis. So we certainly suggest moderation as a general principle. Acutely, the cerebellum, the back portion of the brain, it's associated with balance and coordination, is relatively quite intoxicated with acute levels of alcohol. And so if you have cerebellar problems, which many of our patients do, that could be significantly worsened in the short run. So a whole lot of questions about disco. So I'm actually very happy to finally announce that as of yesterday, our paper was accepted in Lancet Neurology. It took a while, many revisions, but we're very happy it should be published electronically in a couple of weeks. And that's from the disco MS study. But there are a series of questions that are relevant to aging and discontinuing. So this question is, how many factors are there determining how long a patient can be on a DMT, such as type of drug, age, severity of disease, etc. Mostly it's not known. We think of sort of using the medications and in a broad sense, stopping them if there's a reason to. For example, if you don't tolerate it, or if there's some risk that worsens with age, or for example, if you're on Tysabri, if you become exposed to the JC virus, which would give you an unreasonable risk with regard to the brain infection, progressive multifocal leukoencephalopathy, or PML. So there are sort of limiting factors like that. The other way to ask the question is the way we asked the question in the DISCO MS study is it safe to go off medication, DMTs, disease-modifying therapies, as you age? And is there any suggestion as to what are the factors that are associated with risk of recurrence of disease activity should you do a trial off of disease-modifying therapy? And there's a lot of observational data that at least 3 factors are very important with regard to risk of recurrence. 1 is just age, it's better to be older. 2 is disease duration, it's better to be longer. And 3, what has happened recently? Have you had a recent relapse or a recent acute new lesion on your MRI scan? All of those things, if you've had a recent relapse or scan change, if you're younger, if you have a shorter disease duration, are all associated with risk of new disease activity. In addition, there are at least 2 medicines where we always have 2 classes of medicines where we have relatively higher concern should you go off of those medications, again, especially if you're younger. And that is Gilenya and the drugs like Gilenya, so Gilenya, Mayzent, Zeposia, and Ponvory, as well as the generics for Gilenya, and then also with Tysabri. There has been rebound or high recurrence of disease activity occurring anywhere from weeks to months or up to a year after discontinuing those medications. And multiple studies show that there are factors associated with that risk of recurrence. So one would be with Tysabri, for example, what was your prior disease activity before you went on the drug? But also age is a major factor, especially with Gilenya, where multiple studies have shown that older people have a more successful time coming off the drug without recurrent or rebound disease activity. So those are the main factors associated with it. And this Tysabri and Gilenya are the 2 major issues. But have we had people come off medications, and how are they doing? I have hundreds of people who've come off medications, and most are doing well if they are older, like the disco patients, older than 55, long time without having relapses. And disco is an average time of 14 years since the last relapse, and at least 3 years since the last scan change. And then most of those patients were so stable, they've been on still just older injectable drugs. And when they go off medications, the relapse risk is very low. It's less than 2% either on or off drug in that patient population. But there's probably a slightly increased risk of having some new MRI activity. Again, a very small amount, but probably an increased risk of MRI activity. But that was not associated, at least during the first 2 years of the study, with any change in disability. Other studies have shown that 1 or 2 new dots on your brain scan are also not associated with any significant increased risk of disability progression over 5 to 10 years. We'll see. We do have an extension study with disco where we took at least a subset, about 70 of the original patients, and followed them further out up to, I think, up to about 5 years or so to see if there was any increased risk of MRI or relapse activity. So it's going to be different for different people, and it might be different for different drugs. And one specific question relating to Ocrevus, there's been no rebound disease activity that I've seen, and I'd ask everybody else if you go off an anti-CD20 agent, in part because they have more prolonged effects than Gilenya or Tysabri. Rob?
Okay, we have a couple questions here about how to distinguish between MS nerve pain and pain from another cause, such as osteoarthritis or an injury. You know, sometimes it can be tricky, and certainly you can be experiencing both things simultaneously. But in general, you know, certain things kind of clue us into whether something is nerve pain or specifically nerve pain from MS, like the quality of the pain. You know, is it electrical or burning or tingling or something that would suggest to us that it's the nerve itself that's the problem? The distribution, you know, if it's involving kind of like a whole limb or both lower extremities or something like that, as opposed to being kind of more localized in a joint, say like in the knee or what have you. And some of this can be teased out, you know, with seeing the doctor and like getting a good physical exam. I would say a lot of it can be teased out that way. And then, you know, sometimes even if it's still kind of not entirely clear, you want to see, well, what does it respond to, you know? So if we think it might be nerve pain, we'll try to treat with something like gabapentin, pregabalin, duloxetine, those medications that I described. But if it's really not having any impact on the pain versus, you know, rest and ice and elevation and non-steroidal anti-inflammatories or NSAIDs, you know, that tends to work more with a kind of a joint or musculoskeletal type cause of pain, then, you know, those differences in response might help clue us in as well. And so that can be useful, but mostly it's you know, trying to, you know, seeing your doctor and trying to get it examined and see if it may be additional testing, you know, such as an MRI or an X-ray that might be beneficial. And then I'm going to answer this question too, even though it's unrelated, but it's short. How does MS affect bowel movements? I didn't talk about this in my talk, but, you know, MS can affect bowel movements. Most of the time we see it in more of a kind of slowing down way in terms of causing like constipation. I have some patients who, you know, get a sense of urgency or sometimes, you know, incontinence with bowel movements. So that can happen, although that is not the most common thing. And, you know, there are different ways of trying to address that, either by, you know, getting more fiber in the diet or doing something else. Sometimes we'll have, you know, people see a gastroenterologist for further evaluation, you know, because it could be a separate issue. So, yeah.
All right, Amanda?
All right, so I got a few questions regarding the timing of boosters with COVID vaccines. So one of the questions is, do you recommend continued boosters since antibodies wane after 12 weeks? And I've showed you data, even in a normal immune system, not on a DMT, you do have this waning of antibodies at that 12-week mark. And it's probably not practical to get a vaccine every 3 months. We don't know, what that will do in terms of side effects. That's a lot of vaccines. But as we move from pandemic to endemic, what is probably going to be the reality here, and we saw it this year with the bivalent vaccine coming out around flu season and cold season, like all other respiratory viruses, this should become a little more predictable where things tend to come out when we head from outside to indoors in that fall season. And we see a spike in respiratory viruses. So planning your booster around that time makes a lot of sense. And for individuals that have MS or on a infusion DMT, timing can be planned around that as well.
Perfect. I got questions related to primary progressive MS. As it relates to BTK inhibitors, we still have to kind of see what those trials recommend. But what else do we have? What's approved and those things. So, I mean, Ocrevus really remains the main drug that's approved for primary progressive MS. Its effect is modest. And so it's one of those things that we definitely desperately need sort of other options in looking at these treatments. There's other things that are being looked at, but I would say that it's mostly still at the earlier stages of development with a lot of the trials that have come up. I know sometimes just because we don't have stuff, it looks like we're not studying it, but I would say that we just have had a lot of studies that unfortunately have not really panned out in larger studies. So things look promising in small studies or kind of the early phases, and then they get explored in bigger studies and unfortunately kind of fall flat. But there's a lot of interest in this. I can assure you of that part of it. A lot of discussions as to how do we even do sort of earlier phase studies in progressive disease, and how do we look at sort of outcomes in phase 2 studies. And I can tell you that the problem is that sometimes we're not very good at trying to design studies for that. And so there are some challenges, not just from a drug perspective, but in how do we design the studies to try and answer those questions without getting into a really big study that sucks up a lot of time and money to try and get those answers quickly. So a lot of stuff to come when it comes to progressive disease.
So let me, there's a question that I have here that piggybacks on that. So I have advanced MS and I'm wheelchair bound. Is there anything I can do today to slow down the muscle wasting that's occurring throughout my body, especially the legs, chest, and arms? So what do we do if we don't have something right now, or maybe modest benefit from Ocrevus? What do we do now to help with that patient who's losing muscle function?
Yeah, I mean, I think there's still a lot of things that we need to be looking at. I mean, I think that the last 2 talks really kind of address what we have to offer. It's symptom management and it's talking about lifestyle things. And that's a really broad category without a lot of specifics, but it's the idea of trying to maximize and try to get you out doing things. So if you can manage spasms at night, if you can manage that pain, that's going to lead you to sleep better, which is going to lead you to have better memory in the next day because you're kind of going to have that big rest, which is going to let you go out and exercise more, which is then going to make you stronger or at least not wear out as fast. So trying to kind of really push the concept of wellness in all of its forms, I think is the biggest thing that we can really do at this time for a lot of these things. I think it becomes really important not to go into denial from an MS perspective. Even though we talk about progression and progression outside of relapses, what we know is that progression with relapses is the main way we progress, that we get worse from an MS perspective. So we got to take care of that inflammation. And then we can start dealing with kind of this smaller, slower progression that happens in progressive MS. And that unfortunately in MS patients can start really early in the disease process as we're understanding it more and more. And when patients get diagnosed in their teens and 20s and 30s, that they're going to live with this stuff for a long time. So it becomes really important to kind of address and do all those lifestyle things early, and fingers crossed we get a cure or something to address more of that progressive pathology early.
Yeah, I'll just add, we're definitely working on it, but I think we still got to figure out what the relevant mechanisms are that underlie that, especially that kind of non-inflammatory degenerative process that happens in MS, and hopefully some of that will get unraveled in shortly, and we'll have some things that we can offer that are more protective or even reparative. But yeah, at the moment it's just not available.
Yeah, I mean, from a pathology perspective, we're getting into an era that we're learning more and more, but I think it's raising more questions than sometimes it provides answers to things. You're going to start hearing a lot about slowly evolving lesions. These are lesions that are already there that maybe get bigger. Those lesions will last on average 7-8 years, but they evolve really slowly. So trying to see those becomes really hard. We'll talk about lesions that have a perimagnetic rim. Basically, when we look at them, that it looks like they have an iron rim around the outside of that. And sometimes those are lesions that slowly evolve, and sometimes they're not. So there's clearly some overlap between some of these things, and sometimes there's not. And then there's the degenerative process, kind of a whole brain process that kind of happens that we understand probably even less. And these are things that, as we get different treatments, we can learn about. I would say drugs like Tysabri, for example, taught us a lot about how much the peripheral immune system is involved in driving inflammation inside the brain, because we could basically block a lot of that inflammation from getting into the brain with that medicine. And I think, unfortunately, we're kind of using these drugs almost more like, to teach us about the disease, and sometimes we can use mice and rats, as we sometimes do in research. This is a very different disease in many ways than the models that we have in mice with EAE. They teach us a lot, but at the other hand, we still need to kind of see what's happening in patients and in humans. And I think that's kind of what makes it a little bit of a different disease sometimes.
All right. I had a couple of questions about genetics. Dr. Gross mentioned before that one of the old concepts was that pain wasn't related to MS. Another one was that cognitive impairment wasn't seen in MS, that affective problems like depression were not seen in MS, and you had to come up with an alternative diagnosis or reason for that. But similarly, it used to be said that MS was not really an inherited disorder. And that is, in a broad sense, not true. It's just a little bit more nuanced. Many genetic diseases might be, if your parent has it, you have a 50% chance of developing that condition. That's a dominant disorder. It's one gene, you have one copy from mom or dad, not the other copy from your other parent, just requires one copy to cause the problem. Or you could have a recessive disease where it'd be a 25% risk if your sibling has it. They inherited one copy from each one of your parents, so they have two copies, and you have a 25% chance of having that condition, whatever it may be. This is a little bit more nuanced. This is probably a condition like many autoimmune conditions that really is some combination of genetic risk. So there's a genetic background, there are genes that are associated with increasing the risk, but also there are a variety of environmental factors that are relevant to having development of MS, and there's also potentially some genetic involvement with risk of severity of MS. And so we think that there's roughly a 5 to maybe even up to 10-fold increased risk in a first-degree relative of having developed MS over time, with no significant association in one family for severity. So you could have multiple family members. One could have very severe MS, one could have very benign MS. So we are trying to get at this. So a little plug for one of the studies that Dr. Alvarez, myself, and Dr. Schreiner, our pediatrician, or one of our two pediatricians, work on for the adult population. It's called RISE MS, Risk Factors in Early MS, and kids it's called DREAMS, and that's for kids 10 to 17. Essentially the same study. And the concept here is to look at first-degree relatives of people with MS. So if you're a woman who's 43 and you have a 16-year-old child, that child, if asymptomatic and with no signs of MS, we'd be interested in trying to figure out what that risk is. In general, that risk for a girl would be between 3 to 5% of developing MS, and for a boy, it'd be 1 to 2% or so. And we're trying to see, is it really maybe more 10 to 15% in some kids and maybe less than 1% in others? What are the other factors besides just being a first degree relative that are actually associated with that risk? So the way this study works is that we're looking at MRI scans as the outcome measure. That is not waiting for someone to have clinical disease activity. So looking for signs of evidence of dissemination in space, multiple lesions inside the brain that are characteristic for MS. We do a very brief 15 or 20-minute MRI scan with no contrast that looks specifically at MS type of abnormalities, including a marker, another MRI marker not mentioned a moment ago by Dr. Alvarez, that has to do with the lesion itself as opposed to an evolving lesion over time, and that's the central vein sign. And so that's what we're using as the outcome measure, not clinical MS. And we're also then taking a bunch of blood looking at vitamin D levels, Epstein-Barr virus, a variety of other things that are potentially relevant, doing paper and pencil stuff, asking about where they were born, what's their diet, what was their BMI at age 18, exposures they may have had, smoking history and other things. And then also potentially a variety of other things that may evolve over time, especially in blood. We are storing blood that we may go back to interrogate later, with the concept being that we would take the information from the what we call the bioscreen, the paper and pencil information about your history environmentally, as well as your genetic information, and try to come up with a risk score for those who would develop the very earliest signs, even when asymptomatic, on MRI scan. And so we've been doing this now for several years. We have over 150 people that we've screened. One person, in fact, has developed MS. About 12 or 15 or so have a single lesion that looks like it could be related to MS, but nothing more than that. And then mostly we have a whole bunch of normal MRI scans. And we also have begun to have discussions with colleagues at Yale, Columbia, Pittsburgh, and the Cleveland Clinic who are interested in the same questions to try to develop a common data set so we can have much larger numbers and then follow people over time. And so we have started our second round of MRI scans in some of our earlier patients. And indeed, one person did have on the second scan a lesion that was not present on the first scan that does look more like MS. So the concept here is to try to delve into what are the signs, not just genetic, but also environmental, that are either known or unknown, and how can we come up with a risk algorithm so that just like we screen for colon cancer or breast cancer or diabetes or a variety of number of other things, that we could reliably screen. So if you have a first degree relative between 10 and 30, we would love to have you talk to our research people to see if they're interested in participating, and they have to be, again, asymptomatic and willing to participate. Rob?
Thank you. I have a few left here about management of symptoms, particularly pain. First one is, what is the current understanding of an MS hug? How long can the sensation last? How can you manage the pain and discomfort? MS hug, I described it in my talk. It's this kind of squeezing or corset-like sensation around the midsection. We think it's probably caused by a thoracic spine lesion, which are common in MS. It can last variable amounts of time. Often I'll see it in kind of a similar way that we see some of like trigeminal neuralgia and things. Like it'll come on, it may be intense, but then it kind of goes away. You can manage it in different ways. I probably would reach for something like a gabapentin or pregabalin, but potentially also a muscle relaxant like a baclofen or tizanidine. And you could take it kind of indefinitely, or you could take it just to try to alleviate the symptoms while they're happening, and then nothing in between. And then the next question would be, how should neuropathic pain be treated? That's kind of a broad question that my talk went into. I guess I could rephrase it as like, should neuropathic pain be treated? And I'd say generally speaking, probably yes. Of course, we have a bias, but in general, if it's something that is significant enough that you want to bring it up to your doctor, then it's probably something that you'd want to have treated, but it's a very, subjective thing, and it has to do with your values and priorities. And I do have patients who would prefer not to be on medication or anything that they don't absolutely have to take, and I can understand and respect that. And and so, it's kind of dealing, seeing how things evolve over time. And, if it gets to a point where it becomes, just not manageable anymore alone, then, that might be the time to offer treatment. What is the most common complaint in the first year of diagnosis? That, I don't know that anybody's ever asked me that one. It's very varied. It's not any one thing. MS is a very heterogeneous disease. People have all sorts of different issues or combination of issues, including numbness, tingling, weakness, loss of vision, double vision, fatigue, pain, urinary or bowel symptoms. And so, there's not necessarily one that's the most common. I mean, vision and sensory symptoms tend to be fairly common, but motor symptoms too. So that's a really hard one to answer. Another one about bilateral trigeminal neuralgia. How common is that? This person has already undergone bilateral microvascular decompressions, but it's come back. How can you identify a trigger? What are the effective pain management ideas? So yeah, you're getting into that part of the slide where it's already, you've tried presumably a lot of the medications, and it hasn't provided relief. As I said, a lot of times these days, we work in tandem with surgeons, and one of the techniques that they're doing a lot of is this gamma knife procedure. So that might be something to consider for this person. Certainly, working in coordination with like a pain specialist might be effective as well. Yeah, sometimes triggers can be like, infections or increased stress, or sometimes it doesn't have an identifiable trigger. Okay, I'll stop.
Amanda?
All right, I'm going to talk about a different virus now. So we're moving away from COVID. I got a couple questions on PML, which is caused by the JC virus. First question, if someone is JC virus positive and isn't doing well on highly effective infusion, or isn't on highly effective infusions, do mid-level medications work just as well? So I just want to explain kind of the risk with JC virus. If you are JC virus antibody positive, there is a concern certainly for natalizumab or Tysabri. That is probably not the best medication for you. Even if you're negative and you start on that medication and you seroconvert, meaning your antibody becomes positive in the future, that is still a conversation about potentially needing a switch depending on the level of how positive. And most people will switch regardless of how high that is. But there are other effective therapies out there and options out there should you be positive. We live in a really awesome time period, and I can say this probably more than John could 20 years ago, but we have so many choices. There are more than 20 FDA approved drugs now, and so there are options, and therapy can be individualized depending on your risk. For something, I'm just going to use an example of an anti-CD20 because I have the numbers off the top of my head, but for something like Rituximab, the risk of PML should you be JC virus positive is more like 1 in 250,000. And if you look at numbers, you have a greater chance of getting hit by lightning in the state of Colorado compared to getting PML on Rituximab. Now, I did have a patient ask me once, does that include hiking up Pikes Peak during a thunderstorm? Probably not. And then another question regarding PML, are there meds out there without a PML risk other than amino acids? And I'm guessing that that is referring to some of the platform medications, the older medications with injections like Copaxone and interferons. And unfortunately, when there is suppression of the immune system, there is always that risk, although small, in most options of PML.
Incredibly small.
Well,
Yeah.
Like hit by lightning.
Yeah, exactly. Yeah. So for like anti-CD20s, 1 in 200,000 or whatever, with the fumarate's probably like 1 in 50,000. Maybe get a little bit higher with the S1Ps like fingolimod and so forth. But yeah.
And that, so just to emphasize that risk, because I think the way that question was worded, the risk of PML is not greater just because you're on a highly effective therapy. It depends on how that the mechanism of action of that
Exactly.
therapy.
Very much depends on the mechanism, and natalizumab or Tysabri has by far the highest risk in this regard.
I get a little bit nervous when I start hearing the stories about lightning hits, because I brought that up to a patient and she literally told me it's like I've been hit by lightning twice. So,
She
it's
was
a
on
little
Pikes
bit.
Peak.
I don't know where she was at, and
I'd like to know so I can not be there.
I know. My first attempted hike was with my wife was up Evans, and we literally had to abort for lightning. So I mean, it's one of those things that I have yet to have a patient get hit by PML twice. So I mean, I think that at least is a good thing. So anyway, regardless of that, the next question I'm a little bit nervous to answer. It's Rituximab versus Ocrevus. Should one switch to Ocrevus based on recent studies? And this is just sometimes I'm not sure what studies we're referring to, and there's a lot of stuff out there. As many of you know, when you come in and you bring up the latest study on something, and I'm like, sorry, I haven't heard about that study. So based on what I know, I think most of the differences between the CD20s are things that just kind of depend a little on how you're doing with that CD20. And primarily the main reason for us to think about switches, unfortunately, has to do with money. So this is maybe a plug, as many drugs go around generics and things like this, that if you're having a big copay for your drug, to please talk to your provider about drug costs. We can't make them go for free. But with all of these options that we've been talking about, we often have some flexibility to kind of switch to other treatment options or things like this that can make it much more reasonable. Certain insurances like some drugs over other drugs. And so our biggest reason to switch between Rituximab and Ocrevus really has been a switch in insurance issues. Kaiser, Medicaid are really easy to get Rituximab with. United, Anthem, it's really usually has gone pretty easy to get Ocrelizumab for, and those kinds of things. So talk to us. I think there's things that we can kind of do between that. It becomes less of a thing. Another related question around sort of breast cancer with Ocrevus or UTIs. I think sometimes the things that we talk about with some of these drugs are things that are common in MS patients. If you look at MS, what's the poster child of MS? It tends to be 30, 40-year-old women. And what's the cancer that we tend to see in that population? It tends to be breast cancer. So we're going to see some of these things in some of the trials that come up. We've not seen an increase in signal with Ocrevus. If anything, the chances after the trials came out were that it was less of a thing. With urinary tract infections, it's usually an MS thing. It's mostly associated with disability. This is part of the reason that when we start talking about discontinuation and we talk about age, one of the other things I think that we need to really think about is disability level. As patients have more difficulty with moving, it implies that other things are also not working as well. It's easier to choke and you get aspiration pneumonia as the bladder doesn't empty as well. And so you just tend to kind of re-see the next urine and increase the chances of urinary tract infections. And so those are other things that, we tend to primarily think about when we think about an Ocrevus patient. It tends to be that older patient with progressive disease who has higher levels of disability. And so they tend to have more urinary tract infections because, again, their mobility isn't as good. They don't empty their bladder as well. And so I think there's a lot of things that we need to think about when we think about some of these side effects.
I'll just add on real quick because I got a similar question here. With somebody with RMS on Rituximab, does switching to a drug like Ocrevus reduce chances of progressing? So I think in terms of efficacy, within the class of anti-B-cell treatments, you're probably getting the same good benefit regardless of the drug. There may be some mild differences in terms of tolerability and particularly if you're thinking about difference between an IV medication and a subcutaneous injection like Ofatumumab. In general as a class, again, I think they're generally well tolerated, but there may be some slight differences going from one to another, not in terms of efficacy though.
All righty. There were several questions about stem cell therapies. And I'll talk about this broadly. one of my first slides that I put up was about all the different ways you can try to attack or treat MS. And I sort of skipped rapidly over several different categories of things that are mostly under study. One would be neuroprotective approaches. That is, if you have damage from any source to nervous tissue, you can partially damage cells, and they would sort of be injured but not necessarily die. But over time, they can accumulate problems in energy production and other cell important functions that will ultimately result in death of the cell. And we know that shrinkage of the brain and spine is very significant as we age in general, but is actually enhanced with multiple sclerosis and other degenerative conditions. So there is dropout, literally dropout of the cells. So can we protect those cells from being dropping out? Can we enhance their energy production? Can we do anything to stabilize some of the damages that have occurred from previous insults? And so a big impact could be there, and a variety of different agents are being looked at that may be relevant in that regard. Second, we know that the myelin sheath seems to be, at least in part, very relevant in terms of being a target for multiple sclerosis. And the myelin sheath is like helps conduction. It's like an insulator around the nerve and allows better conduction. If it's partially damaged, it will not have the electrical current go down the nerve as rapidly and as successfully. And so could you have remyelination strategies? And a number of those have been looked at over time. Unfortunately, none of them have shown much. At least one, clemistine, has at least shown a very modest impact on actually measuring the electrical conductivity, but no significant benefit on visual function. A third approach would be to actually regenerate nervous tissue. And so then you're asking the question, could you literally grow a brain? And there are approaches that would maybe get at that by using neural stem cells. That is, the stem cells that have generally been used so far. And again, I'll put a shameless plug in for one of our studies, the Beat MS study. This is the best available treatment study. Most of these studies have been done with bone marrow derived stem cells. And the concept is that you would take stem cells out of the person and their own stem cells, and you would store them. Then you would disrupt the bone marrow at different levels of significance, sort of low, medium, and high. And then you restore bone marrow function with the stored cells, the stem cells. And so essentially you would reboot the immune system. So this is immune therapy. And the concept with the Beat MS trial is to look at individuals who in previous studies have shown perhaps the best benefit in this approach. And as individuals are generally younger with relapsing MS and recent disease activity with recent relapse. And so in our study, you have to have 2 relapses, at least one while on drug, and you would then be a potential candidate to get either what I just described with the chemotherapy and stem cell rescue, or you would get best available therapy, which would typically mean either cladribine, an oral drug, or one of the monoclonal antibodies, of which we were just discussing in detail, Ocrevus, Rituximab, ofatumumab, alemtuzumab, and presumably now Briumvi, Ublituximab. So that's the Beat MS study, but that study is focused on, again, rebooting the immune system. If we want to try to regenerate the nervous system, we're going to want to have not bone marrow derived stem cells, but neural derived stem cells, cells that have started to differentiate, and they've gotten past a point where they're not going to become a kidney or a skin cell or an eye cell or anything else. They're down the track to become nervous system tissue, but they're not fully differentiated. And you can create these in some senses in the laboratory, and then you can grow them. And you can put them in intrathecally into the spinal fluid. And this has been shown in animal models of MS to be potentially quite helpful. And a small number of studies have looked at this process in patients with progressive MS because A, greatest unmet need, B, they have the greatest loss of brain volume, of actual shrinkage of the brain due to dropout of cells, where you'd want to regenerate them. And the concept is that it would do one of two things, or perhaps both. One, it would simply replace the cells that are damaged, or two, and more likely, these cells would actually bring with them and emit various growth factors that would then have an impact on cells that are already inside the brain and spine, who have these cells have the capacity for regrowth, but are somehow being inhibited. And this would potentially disinhibit them, allow them to fully differentiate and actually become nervous system tissue. And so these are studies that are in their infancy, and the hope is that they would offer some kind of regenerative approach. You could also, in theory, sort of skip the cell part and just come up with growth factors that you could also use that would do the same thing, but just not deliver the cells that would give the growth factors. So there are potential ways to regenerate nervous system tissue. This is relevant, obviously, not just to MS, but to Parkinson's, to Alzheimer's, and to many other degenerative disorders. So there's a great deal of interest in this kind of approach, but this is a much harder problem than bone marrow-derived stem cells, which by themselves are an incredibly hard problem. So this is a bigger biological issue and much more difficult, and all of those kinds of things are in their infancy.
Okay, I have a few questions to kind of segue on about brain volume, brain shrinkage. Does Ocrevus slow down brain shrinkage? What current medications? How do they deal with brain volume loss? And then yeah, let me handle those first. So yeah, not terribly well. I mean, yes, to a certain extent. If you looked at the original phase 3 clinical trials involving Ocrevus compared to interferon beta and relapsing remitting MS, I happen to know that there were two trials, identical trials. One study found a 14% relative reduction and the other a 22% relative reduction in brain shrinkage with Ocrevus. So in general, really not that great, and really not most of our immune-based treatments. We're not really seeing like huge benefits in terms of slowing rates of brain atrophy. Although, to be honest, it's not something that we've necessarily been looking at for a long time. And there are some challenges in terms of trying to develop a standardized approach in how we actually measure this. Certainly, we're starting to do it more on just the routine clinical side, but it's probably not done as accurately as it is in clinical trials. But yeah, I mean, it just kind of emphasizes the fact that we do need to find other potentially non-immune based drugs that can slow down rates of brain volume loss that could potentially be used, even in addition to somebody's existing disease modifying therapy and further modify the disease, but just in a different way. So yeah, more to come on that, hopefully. And then a couple of questions about cognition. So how does MS affect cognition? Does the location of the lesions have anything to do with it? And what about the presence of black holes on cognition and brain affect? So black holes, just again, are what you can actually see on MRI, a particular sequence, T1 sequence on MRI, where they look dark, and that's because those nerve fibers have actually been lost. So they're not just demyelinated, but presumably those fibers are gone. And so, one potential mechanism actually of figuring out is something, neuroprotective or regenerative would be if you looked at a lesion when it's newly developed, say on our standard kind of flare sequence, and then you look to see, whether it became a T1 black hole on subsequent testing. You could try like a drug, you can do a randomized control trial and see if it led to fewer of these black holes and hence protected the brain better than the comparator. So that would be one way of potentially doing it. One way among several different ones that I think Enrique was talking about. But yeah, certainly brain lesions can affect things in the brain like cognition, and we know that cognitive symptoms are quite common in MS. In some instances, they can be quite severe, although in many more instances, they tend to be kind of a more mild to moderate range. But they can affect, daily activities. They can affect employability and various things like that. Yeah, in terms of the question is dementia and aging process worse with MS? I mean, we all get older, and dementia risk increases. I feel like I got louder all of a sudden. Dementia risk increases as we age. To the point that you're in your 60s, you maybe have like a 1 in 10 risk of getting dementia. Most common form being Alzheimer's, and you're in your 80s, it's like a 1 in 3 or 1 in 4. And so that's way higher than MS and all that other stuff. But of course, again, MS, cognitive impairment, tends to be quite common as people get older with MS. If they start to have a more pronounced issue with their memory or their cognitive function, then and then we don't see anything that would necessarily suggest that the MS has progressed in other ways, then that might be worth thinking about. Well, could this be some additional or separate neurological process like Alzheimer's or something like that, in which case further testing might be in order. But it's a tricky thing. All right, I'm gonna move on.
No, it's all good. We're at time 0. And I wanted to put a small plug in. Dr. Shah's not here today, but she's very interested in pregnancy, lactation, other hormonal related issues. So if you have those issues, she's particularly interested in people helping with that. But I mostly wanted to say sorry if we didn't get to your question. But we tried to stack these the best we could to cover as much territory as we could. And thank you very much for coming. We very much thank our partners, the Rocky Mountain MS Center. A number of questions we didn't get to had to do to, what about resources for fill in the blank? Well, they are the resource. Also, National MS Society is a resource. MS Association of America is a resource. But our local resource, who love you and always will love you here in Colorado directly, is the Rocky Mountain MS Center. So thank you very much for coming, and have a great day.